Look at our friends joining us. Good to see you, Beth. Good to see you, Kim. Rick is joining us. This is good. Bev and Arnie are joining. Lovely.
For meeting housers, that's prompt.
I'd say. Georgina, welcome to you too. Do you hear some laughing and giggling in the background there, Stephanie? Mm-hmm. It's close to Ezekiel's bedtime, and it sounds like stories have ended and tickles have begun.
Okay, whatever works, right?
Absolutely.
Our neighbors they have 2 young boys, and they called this time Power Hour because it just turns up for that last like 30 minutes, and then boom, you know.
We just got a puppy, and the puppy has a power hour, that is for sure. Yeah, I would call it crazy hour, actually.
Well, Zoomies are always welcomed, though, to a point.
Zoomies, that's right. Yeah.
Very good. I'll say welcome everyone who's come to join from the waiting room. I see we've got a handful of people. We won't wait tremendously long, but you'll see this slide here. SARS-CoV-2. Did you say CoV-2? That's how you say that, Stephanie?
SARS-CoV-2, yeah.
Nice. The virus, vaccines, and drugs. And if you don't know, Stephanie DeWitte-Orr, who is Dr. Stephanie DeWitte-Orr, but she said we can call her Steph or Stephanie. She's a virologist and an associate professor in the departments of health sciences and biology at Wilfrid Laurier University. And we're really happy to call her a friend and family of the Meeting House Waterloo. So we'll wait a little bit longer just for some more friendly faces to join our call here. There's still lots of giggles going on in the background. Yeah. Megan, good to see you joined.
Thanks, everybody.
Glad you're here.
It has a nice, pleasant setting for our talk today.
Yeah.
Yeah.
I had another question come in, so I'm adding this to our document here, Stephanie.
Okay.
So that's a pretty practical question there, Steph, if you go to our document. It's question number 6. Patty's joined us. Very good. Very good. All right, I think we'll get started in 1 minute. So thanks, friends, for sitting tight and waiting. If you want to grab a quick coffee or a cup of tea and settle in, you can do so.
Now I could talk.
You can say hi if you want. Oh, unless you got muted by Andrew.
Hi.
Hey, Beth. Thanks for coming. I appreciate it.
Oh, no. It's good.
Your video's on there too.
Nice. Okay, I think we'll get started. Birgit, good. Some more folks are coming in still too. So even as people come, that's totally okay. Thank you everyone for coming so far. I am so excited for everyone who's come, and I'm especially excited for our guest Stephanie DeWitte-Orr, who is a virologist and an associate professor in the departments of health sciences and biology at Wilfrid Laurier University, and who also calls the Meeting House Waterloo home. I chatted with Stephanie because there's actually I chatted with someone else who was like, hey, I had a conversation with Stephanie about, COVID and vaccines, and friends who have lots of concerns about vaccines or if they should take them at all. And I know in talking with other parishioners, other folks at the Meeting House, that this can be a pretty divisive issue because of information. And information is all over the place on the internet, on YouTube, and as well as, the New York Times and other newspapers and other places to get information. And I think this is something that's really important, our health. I think we all value our health, the health of our family members. And in this time of a global pandemic, which is, use whatever adjective you want, unprecedented is one that keeps coming over and over. And I'm sure we're sick and tired of hearing that word, this unprecedented times. Other words like pivot too, we have pivot this, pivot that way. But I wanted to hear from an expert, someone who's been working in this field. And so we'd also have time for a Q&A. So what's going to happen tonight is we're going to hear from Stephanie. She's going to share a bit of a presentation. She's been sharing, on the radio, on TV, even about her research during this time, which is really cool. And so she'll share a bit, and then we'll have time for Q&A. We already have some questions submitted, which we'll get to some of those, but also we can have live questions, and you can unmute and share as well. And so I'm excited for that live Q&A session as well too. I'm going to open in prayer, and then I'll hand it off to you, Steph. Jesus, thank you for tonight. Thank you for who you are, for how you've made us and given each of us gifts, and someone like Stephanie who has gifts, but also skills, and honed and worked on life and research in her field, and that she can share that with us and share that with, as is recorded for whoever comes and hears and learns. And so I'm thankful for her. And for this time. So we also pray too for health. We pray for our world. There is still a global pandemic, and we are privileged to be in a place where there are many vaccines that are very accessible, and we do feel like we're coming out of this, but there are other places where it's a lot scarier. And so Jesus, I'm grateful for vaccines, and that, the science has made it this far so that we can, feel that the loving thing to do eventually soon is to be together with other people. Whereas so far as a church, we felt that the loving thing to do is to not meet in especially large and indoor gatherings. And so we pray for other places in the world where that's not the case. And we pray for this pandemic to come to an end so that we can hold each other and love each other in those ways, by being together and being together in person with one another. So be over this time, Jesus. And thank you. Amen. All right, Stephanie, go for it.
All right. Thanks, Jordan. Can you see my pointer, my arrow that I'm moving?
Yes, I can move it. Yes, it's moving.
You can see it? Okay. Just so that if I point at things, I know people can see it. So what I have quite a few slides here, and I'm not going to give you a full lecture, which is what I'm tempted to do as a professor, is to give you a lecture, but I won't. But I have the slides just in case we have a question related. Then I have the resources available to go back to that slide to show you a little bit more detail. So I'm going to go through the slides quickly, but we can always go back to them if there's a question related to the slide. So we're talking about SARS-CoV-2, and this is SARS-CoV-2 here. This is what it looks like under an electron microscope. So you can see that I'm going to tell you a little bit about viruses. This is a virus. It has a protein shell, and inside the protein shell is RNA. And RNA is the code to make more of this virus. And the part of this virus that I'm sure you're familiar with is the spike protein, because that's what everybody's talking about. And the spike protein are these little protrusions that come out of the virus. They create a halo effect or a crown effect around this virus. And that's where corona comes from, is that it looks like the sun, or it looks like this halo around the virus. So that's why they're called coronaviruses. I think it's important to start this conversation with defining what we're talking about, because maybe before this, you've never really thought about a virus or what it looks like or what it does. And I cannot stress how small a virus is. Until the 1930s, we'd never seen a virus because they're so small, you need an electron microscope to see them. That's how small they are. This is a cartoon of a coronavirus, and you can see the red part here is a protein shell that protects the pink RNA on the inside. And this yellow is that spike protein we were talking about. And the spike protein is important because it's the part of the virus that the virus uses to bind to our cells and get into our cells. So the spike protein is the key that binds to the lock on the surface of our cell that allows the virus in. So these entities are so small you can only see them with an electron microscope. What they do is they get into a cell, that protein core releases, the RNA is now inside the cell and is used as a template or a guide or a map to make more and more copies of this virus. And those viruses then assemble inside the cell. And eventually that cell will break apart in a lot of cases to release the virus so that it can infect new cells. And you get sick either because the virus has infected cells and those cells have died and that's making you sick, or the immune system, your immune system is reacting to the virus and is causing you to be sick. And a lot of the symptoms of SARS-CoV-2 is actually not because of the virus, but because of your immune response to the virus. And so just to give you some scale about SARS-CoV-2, it is 120 nanometers in diameter. That means from one side to the other side. Just to give you a scale, human hair is 75,000 nanometers in diameter. Okay, so we're talking a very, very, very small entity. But saying that, the SARS-CoV-2 virus is actually one of the biggest RNA viruses out there. And that's actually important because this virus has such a large genome, that RNA is so big, it actually has something called a proofreading enzyme. And this is really important because that proofreading enzyme helps make copies of the virus without mutating. And so the mutation rate of coronavirus is way lower than something like influenza or HIV. That's really important because the variants that are coming up would be way more frequent if this was a different kind of virus. So we're actually lucky it's a coronavirus because there's much less mutations than it would be if it was something else. Now, what is SARS-CoV-2? It is a coronavirus. It's a beta coronavirus. It is very similar to coronaviruses that are circulating in bats. And we can talk about, if you want, where I think or how I think SARS-CoV-2 emerged. But so we'll just leave that for now. But what I think is important to know is this term called zoonosis. And this is when a virus jumps. So when you listen to the media and you hear, oh, the virus jumped from a bat to a human, I think it's important to note that viruses don't have legs. They physically cannot jump. What it means is that there is a virus that was in, let's just say, a bat. And it was in that bat and it was replicating in the bat. And then as it was replicating, making copies of itself, it made a mistake. And when it made that mistake, it's actually a good mistake. It's what we call a gain of function mistake. It was a mistake that allows the spike protein on this new virus to bind to human surface receptors, human ACE2. So sometime in December 2019, there was a SARS virus in a bat that mutated. So now it could bind to a human ACE2 receptor. Around that same time, a human had to have been in close contact with the bat and inhaled the virus. And now this mutated form of coronavirus got inhaled into the human airway, got to infect the airways. And now it jumped from bat to human. Okay, and that's how this zoonosis happens, just a random mutation in an animal that all of a sudden, now that virus got breathed into a human and now can replicate human cells, it gained the function to do that. And we're all aware of the clinical manifestations of a SARS-CoV-2 infection. So just so you know, SARS-CoV-2 is the name of the virus. SARS stands for severe acute respiratory syndrome. CoV is coronavirus, and 2 is the second because the first one emerged in 2002. COVID-19 is the disease caused by SARS-CoV-2. So SARS-CoV-2 is the virus, COVID-19 is the disease. So I'm sure you've heard of the variants. The WHO has renamed the virus variants that have been emerging with Greek letters. So what I want to take, what I want you to take from this slide is, one, that alpha through gamma variants, the symptoms are, major symptoms are cough, fever. There should read fever there. I've deleted that by accident. Fever, cough, and loss of taste and smell. But the Delta variant's symptoms are different. So the Delta variant is the new variant that seems to be taking over the globe right now. And it's important to note that those symptoms are headache, sore throat, and runny nose. So it doesn't have the same symptoms as the other variants. So if you start getting some of those symptoms, please be aware and get yourself tested. There's really not a treatment that's available that's shown to be effective. And the best treatment we have is antibody treatment. So we can talk about that if you want to in the Q&A. How is SARS-CoV-2 transmitted? Well, mostly through respiratory droplets. So that means coughing, sneezing, singing, enthusiastic speaking, anything that gets these droplets out of your respiratory tract, because the virus infects your airways first. And so that's where lots of virus is. And so when you cough or sneeze, the virus leaves your body. And there's some of the really tricky things here is that people can be asymptomatic and still transmit this virus. So you'd have no symptoms yourself, but you're able to transmit the virus. And that's what's enabling this virus to spread so fast and so well, is that people don't know they're sick and then they are spreading it to other people. I do want to mention masks, that cloth masks. It's funny because I went on the news when cloth masks first started, and I'm like, cloth masks are not effective. You need an N95. And it just shows you how everybody in the scientific community is trying frantically to keep up with research, because cloth masks actually do work and they are very effective. And I can talk about this study here from the United States that shows that cloth masks are actually very effective. Now, one thing I want to highlight is when, like I said before, this is our coronavirus here, and it binds to ACE2, that's the receptor in your airway. So this is the lock. So this is the key. This is the lock. They match each other. The cell opens up. The virus can come in. The RNA is here. It's used to make lots of copies of itself. The virus makes lots more proteins, makes more RNA, makes more virus, and now the virus can leave the cell. So when you have millions of people being infected with this virus, every time this virus replicates, it has the chance to make mistakes. Every time. And so it's a numbers game. When you have millions of people being infected with this virus, you increase the chance of this virus making a mutation that's going to help it. Okay. So I think this is an important thing to note, especially when we're talking about vaccines and vaccination rates. We're talking about two things. One thing is, in a community, reducing the amount of people getting infected, because if you reduce the number of people infected, you reduce the chance of the virus mutating, you reduce the chance of variants arising. But that doesn't just apply to a community. This applies to the whole globe, because the Delta variant arose in India and is now taking over the globe. So we need to stop the virus from being able to replicate around the world to reduce the chance of mutation, so that we reduce the chance of variants arising. because every time a virus enters a cell and replicates, it has the chance to make mistakes. Many, many of those mistakes are going to be loss of function mutations, which means the virus doesn't work anymore. But sometimes the mutations are gain of function, and that's when you get a new mutant, a new variant that's going to be even better at transmitting, even more able to cause disease. And that's why we keep seeing these variants rising. So it's very normal for viruses to mutate. It happens all the time. As I mentioned before, coronaviruses actually have lower mutation rates than some other kinds of RNA viruses. So that's good news. But the more people getting infected, the more chance we get more variants. And so you can see with SARS-CoV-2 over time, we've had variants happen. We had the D614G variant that came right after emergence in December. We had a new variant coming in January, February of 2020, and it became the dominant form globally by June 2020. Then we've had the Alpha, the Beta, the Gamma, the Delta variant. The Delta Plus is coming, and there's the Lambda variant that's in Peru right now. That's a variant of interest. So what I think is important to think about when you're thinking about, should I be vaccinated, or what do I think about vaccinations? It's not just protecting yourself, but also reducing the chances of, if you do get infected, you could be you would be an individual where the virus is replicating and creating mutations, and more chances of replication means more chances of variants arising. So the Delta variant, which is the one I talked about with different symptoms, so is also has, each time this virus mutates for a new gain of function, it's going to get even better. It's going to transmit better. It's going to infect better. It's going to replicate better. And so far, the variants have been close enough to the original that the vaccines still are efficacious. But the longer we wait, the more chances this virus has to build on itself, the more chances that we'll get a variant that's going to deviate so much from the vaccination reference strain that it's not going to be as effective anymore. All right. Okay, so herd immunity. Now, this is something we can talk about, and I can explain it. I probably don't have time now, but if you want me to, I can explain herd immunity. Vaccines, what is a vaccine? I think what's important about vaccines is to know that it's very normal to feel nervous about vaccines. Ever since vaccines have started, there has been worry about vaccines. If I have a minute to tell you a story, one of the first mass-produced vaccines or mass-used vaccines was developed by Edward Jenner, and it was for smallpox. And the vaccine in that case was a cowpox. Okay, so this was a pox virus that they took from cows, and they put it into humans. And because cowpox and smallpox were similar enough, if you had a cowpox infection, you wouldn't get sick, but you'd be protected against smallpox. And there were cartoons at the time in the 1700s that were being published expressing the worry that getting cowpox would make you a cow, or would somehow give you elements of cowness. And that was, hundreds of years ago, this concern, what is this vaccine going to do to me? Is it going to change me fundamentally? Is it going to do something to me? Is very normal and has been a concern for a very long time. So I just want to reassure you, if you're concerned about these vaccines, it's a very normal feeling. And also, it's something that you give to a healthy person. And so you think, I'm healthy. Why would I do this? Why would I, have a vaccine? So anyways, it's a very, I think it's very natural to have concerns about that. So I want to put that out there. I can explain, maybe I should spend a second here. A vaccine is something you give a healthy person to stimulate their immune response so that their immune response remembers that virus. So when you get the SARS-CoV-2 vaccine, your immune system is going to remember that virus, so that when you actually, if you are ever really infected with that virus, your immune system already remembers it. And so it will mount a faster and stronger immune response against that virus because it thinks it's a second exposure. It thinks it's the second time it's seen that virus. And so you won't even know that you got sick a lot of the times, that you were infected. You never get sick because your immune system remembers and eliminates the virus. So this is just a slide about memory. The difference between a vaccine and an antiviral drug. An antiviral drug is something that you take if you're already infected, whereas a vaccine is something that you take before you're infected to stop the infection. I can tell you that antiviral drugs are not very effective against viruses. We don't have effective antiviral drugs. They don't work. And I can explain a lot of reasons why we don't have effective antiviral drugs, but I think it's a dangerous, let me change that. I think at this point, choosing to not get vaccinated, hoping that an antiviral drug will be an effective treatment may not be the right strategy. We can talk about components of a vaccine, what's in a vaccine. I can show you this slide to show you how effective vaccines have been in the past. So you can see this is a scaled diagram for how many diphtheria cases there were from 1910, 1940, a vaccine was introduced, and by 1960, there's no diphtheria. And you can see that for all kinds of different vaccines, that they are effective. Two great examples: smallpox, completely eradicated from the planet. Polio is coming up close to second to be eradicated because of vaccines. There are many different vaccine strategies for SARS-CoV-2. This is the traditional vaccine strategy. This is using a weakened or attenuated virus or an inactivated virus. This is what all of the vaccines you've been vaccinated with, this is the platform that we use. And what I can tell you is when this virus first emerged, this was the platform, of course, that we went for. We wanted to go for this. Unfortunately, it doesn't work with SARS-CoV-2. Or you could flip that and say it actually works too well. When you try to use inactivated SARS-CoV-2, well, okay, so there's a couple from China that are based on this platform, and they have about a 50% efficacy. So that's very, very low compared to some of the other vaccine strategies. The coronavirus is very difficult to grow. So when you do this kind of strategy, you need a lot of virus, and we can't grow it at that high of a level. Some of the vaccines based on this platform, like I said, don't work. Or they worked too well. They induced what's called neutrophilia of the lung, and the lungs of the animals being tested would have been dramatically inflamed. So this vaccine platform was not proving to be fruitful. And so a lot of scientists and pharmaceutical companies chose not to pursue this vaccine platform. The viral vector vaccine. So this is the Astra Zeneca vaccine, or the Johnson & Johnson. We can talk about those if you want to, about how they work. Protein, subunit, and virus-like particles are being developed, but they're not available in Canada. And of course, the RNA vaccine is the one that is the front runner now for everybody. And we can talk about how this works, how the RNA vaccine works. I wonder if maybe I'll just spend a minute to give you a little bit of background on this RNA vaccine. So Pfizer and Moderna both make an RNA vaccine. Remember, we said RNA is inside the virus too, right? RNA is used as a template or a map or a guide to make new proteins. And so the RNA inside this vaccine codes for pieces of the S protein, that spike protein. Now, it doesn't code for the whole S protein. And some people are concerned that the S protein that's going to be made is cytotoxic or can cause bad side effects. But I think it's important to know that the pieces of the RNA that's the coding here is just pieces of the S protein. So the cell never makes a full SARS-CoV-2 S protein, just little pieces of it. So we've got this RNA encoding for pieces of the S protein encoded in this fat bubble. It's called a lipid coat or lipid bilayer. And so that's injected into your arm. Now the cells, the muscle cells in your arm are going to take up that RNA. So that lipid, your cells are all made out of lipid, of fats. And so this lipid bubble is going to fuse with the coating of your cell, and the RNA is going to enter into your cell. Okay. The RNA is going to code for pieces of S protein. Those pieces of S protein are going to get broken into pieces and presented on the surface of the cell to the immune system, to talk to the immune system and say, hey, I have this weird protein. It's not mine. Remember this. Okay. And then the immune system will say, oh, I have a receptor that matches that. Yes, I will remember this now. And then those immune cells go away. Now, what I think is really important to note here is that the RNA in this cell lasts for 4 to 10 days. That's it. And then it's gone. The protein would last about the same amount of time. So maybe 14 days for the protein. And then the protein is gone. So it's not, this vaccine doesn't stay in your body for a long time. It just stays in your body long enough to make that connection between the S protein and the immune receptors, so that now the immune cells remember that S protein. Now, the lucky thing is that these immune cells with these matching receptors, they do hang out in your body. Now, we don't know for how long, to be honest. Coronaviruses usually don't mount very strong immune responses. So it's possible that this immune cell, the matching receptor, will only stay around for a couple of years, which means the vaccine will stay around, will have memory for a couple of years, and then you might need a boost, a reminder. Or some vaccines last for your lifetime. You only need to make that connection once, and that memory cell is around for your whole life. But the vaccine doesn't stay around. It's just the immune cells that stay around. Okay. And of course, we know that Pfizer and Moderna are the RNA vaccines. They were both developed in the States. They need 2 doses. They have excellent efficacy. And this efficacy is changing with the variants. So what I'm showing you now is efficacy with the Alpha variant. With the Delta variant, they're decreasing. So for Pfizer, Moderna, it's about 80 to 85% efficacy. And the Astra Zeneca is about 60% efficacy with the Delta variant. The nice thing about AstraZeneca is that it doesn't require that really cold temperature of Moderna or Pfizer for storage, which isn't a big problem for Canada because we have money and we can buy these really super cold freezers. But in other parts of the world, that's a problem. Oh, and just this is just my last slide. I have been working on coronavirus antiviral drugs myself. And so these are human lung cells that we grow in dishes. And when you add a coronavirus, in this case, this is 229E. So this is not SARS-CoV-2. This is another coronavirus that causes the common cold. And you can see there are no cells here because the virus killed them all. Remember, we talked about how the virus can get into a cell, replicate, make lots of copies, and then it can blow up the cell when it's done. So it's blown up those human cells. But when we add our antiviral drug, you can see that the cells are all protected. So we're working on moving this to test with SARS-CoV-2 at McMaster University in their level 3 lab. And I think that's it for background that I wanted to give before we started the Q&A. Hope that wasn't too long, Jordan.
Wow, no, that was amazing.
Thanks.
I was like, maybe I'll take notes, and then I got a sheet of paper, and I have a nice full page of notes. I'm so thankful. I think that was like so informative, and so like you hit at the right. Oh, Megan's commenting here. That wasn't long enough. I could have listened and learned for much longer. So I think a lot of people here would have been in for your 2 hour or 3 hour lecture. However, not everyone might be in for that, but I again, thank you. I thought that was so well, clearly explained, and I think you hit a lot of big questions already that people may have already had. But you left room, like we can go into this, we can go into that. And so, yes, comments are coming in. Thank you so much. That was so helpful. Agreed. So helpful. I think people submitted questions ahead of time, so I think we'll get to those, and then we'll jump in and we'll say, hey, people, if you want to unmute and ask some of your questions live, we'll do that. Actually, one of these questions that came in ahead of time was from someone here, which was, will you eventually get COVID if you're not vaccinated? Question came from Beth.
Right. So I don't know.
Okay.
If you're vaccinated, the chances of you getting COVID are significantly lower, 95% lower. As your community increases its vaccination rate, you're going to have less and less likelihood that you're going to be infected because of herd immunity. So if we go back to here, if we look at our community, if we have someone here who has COVID-19, and we have a few people who are vaccinated, but most people aren't, the chances of this infected individual running into other people who don't have immunity is quite high. So the virus is going to spread very easily because this person's going to meet these two people, they could get infected, then they're going to meet these three people, and so on, and it just moves through the community. So the chances of transmitting the virus in this scenario is very high. In a scenario where most of the community has antibodies or has immunity, has been vaccinated, the chances of this infected individual running into somebody who doesn't have immunity is much lower. And so the virus slows down its transmission because this person actually doesn't run into anybody who's susceptible to infection. And so the virus replication stops with them. Now you notice there still is some replication. There is some transmission. So it's not bulletproof. So I couldn't say, would you be guaranteed to get infected? No, not necessarily. It depends on who you run into. But could I say that, you're much, much less likely to be infected if you're vaccinated? Yes. And yeah, that's all. It depends on your lifestyle, how much you see people, how often you interact with other people, whether you want to isolate for longer, things like that.
And there appears to be a half question. I think if people who have had COVID already, can they get it again?
Yeah, so that is a really good question. There is evidence that you can get infected again. It also depends on the severity of the infection. So this is a real bummer. If you have been infected, but you're asymptomatic, so you don't know you're infected, and yeah, those individuals actually don't mount memory very well at all, and they can get infected again. And there's no guarantee the second time around you'd be asymptomatic again. So, yeah. And with all the variants that are happening, it's very difficult to know whether if you were infected with Alpha, would you still have protection against Delta? Probably, but it's hard to say. Human immune systems, my immune system is not the same as Jordan's. How those receptors that I was talking about, mine are going to see it a little bit different than Jordan's, and mine are even going to see it different than my brother. And so we might have completely different, it's called an MHC haplotype, my brother and I. So it's even difficult to know between family members how people would respond.
Interesting. Again, similar vein, Megan adds here, some concerns that they've had from family or friends is that, if they've already had COVID, they don't need the vaccine because they've already had the virus in their system. So what would you say to that?
Yeah, so a few things. Again, if they had a very mild case of the virus, their immune system might not have mounted a strong immune response. So public health is still recommending people who have been infected to get vaccinated. The vaccine mounts a very robust immune response in most individuals. So you're better guaranteed to have a good, strong memory response if you're vaccinated. If you have been infected, we can't guarantee how strong that memory is. There's papers with different coronaviruses, obviously not SARS-CoV-2, but the memory from a seasonal SARS infection, a seasonal coronavirus infection, not SARS. The memory lasts for about a year, maybe two. So we just can't guarantee how strong that memory is if you've been infected before.
And is a strong immune response similar to, I'm going to say, bad reactions? So I had Pfizer, and I recently got my second Moderna shot, both through the region of Waterloo, and I had pain in my arm, but I didn't have very much. I have another friend who had a very, 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 very strong response, and I actually brought her to the ER because of how bad it was, and they wanted to run tests. She's fine, right? But it was concerning enough that it was recommended that she go check herself in. So what's the difference there, or why is there such a, I'm going to say, variance in the reactions, if you know?
Yeah, so that's down to those receptors again, and how people have different receptors that recognize that S protein. Some people's receptors are going to bind really strongly, and they're going to have, or they're going to have lots of different immune cells with lots of different receptors that are going to respond. Some people are going to just respond, maybe they'll only have one or two kinds of receptors that will recognize the S protein, and so they won't mount as robust of an immune response. Some of that you're also feeling there, especially that immediate pain or that feeling of achiness that happens in the first day or two, is actually your innate immune response. So we didn't go into this, but there's two arms to the immune system: innate and adaptive. Adaptive has the memory, so that's what you want your vaccine to mount. But that first initial response is super important because the innate actually recruits or brings in the adaptive immune response. So you want a strong innate immune response, but the innate immune response makes you feel crummy.
Okay.
It's that flu, achy joints kind of feeling. That's your innate immune response. Those are cytokines that are being released. So if you feel that way, it stinks, but it's actually really good because that means your immune response is recognizing the vaccine and is recruiting. Now there's a balance there, right, Jordan, with your friend who had too much. And that's a little bit of the bumpiness of, the vaccines being developed quickly. And, dosage might be a little high for some people.
Sure.
But that's probably an overreaction, or too much antigen was being produced in that case.
Question about ages that came in the chat. So why do different people respond differently at different ages? Like for kids who get Pfizer, especially 12 to 17, and the Astra Zeneca was one that was, make sure you're not of this age. So what's going on there?
So your immune response develops as you age, and then it starts slowing down. So when you're young, your immune response is still developing. So that's why they've gone to 12. They're actually doing phase 3 clinical trials this summer from ages 12 to 6 months to see, to test the younger ages.
Oh, wow.
But when you're growing up, your immune response is learning, and it's adapting, and it's developing. Then as an adult, you're hitting your prime years of immune responses, and then unfortunately it drops pretty darn early. So in your 40s, it starts going downhill. And so when you're in your 60s, it's really depressing because I am in my 40s. In your 60s, it really goes down. So some vaccines are going to be very effective for people in certain age groups because your immune response is responding well to the vaccine in that age group. And then for AstraZeneca, well, that was one where they were doing reactionary public health measures. So in that case, you get vaccines, once you get to large numbers, weird things start popping out. And so this blood clot thing with AstraZeneca, they were changing the ages based on risk to blood clots, but that was just a reactionary public health measure.
Okay, no, that's great. That's really good. There were some questions about the speed of the development of this and concerns about especially reading reports, whether that's from the US CDC or wherever else. It's like, oh, this is emergency use, but there's not this official approval process, and concerns about long-term side effects because it's so new. And yeah, was there proper testing? These are safe because of this quickness of this. So maybe just respond to some of the questions about speed and emergency as opposed to maybe slow and quote official, or the differences there.
I think so there's a lot to say about that.
Okay.
One of the first things I would say is that because there's a lot of vaccine hesitancy, normally changing vaccine platform strategies is something that's not done unless it has to be done. So far, we haven't really had to change platforms because they've worked. The inactivated vaccine strategy, that inactivated virus vaccine, has worked. So that's what we tried for this one too. And then it didn't work, or it doesn't work very well.
Yeah.
Or we just can't make enough virus, lots of different reasons. So then scientists had to look at different platforms, different kinds of strategies. The RNA vaccine strategy the development started in the 90s. So it's been around for a really long time.
Wow.
Yeah. It's just that the other one worked. So why change when we have a platform that's proven safe, that people accept, that this is okay? You don't rock the boat. But then when you get to a global pandemic with a virus where the vaccine, that strategy just doesn't work, well, then you have to change the platform. And honestly, that's, I think, the reason why we went with RNA vaccines. But I kind of wish we did it sooner because they are so effective. And to be honest, I've taught about different vaccine platforms for a long time, and I have a soft spot for the RNA vaccines because they're so elegant. They're just so efficient. They're just some RNA and entering some cells, making a little protein, and then they're gone. They're not complex. They don't have a lot of moving parts. There's, being worried about long-term side effects. There's really nothing there to last long term. There's nothing there that could cause you harm long term. Now, putting on if you're a scientist, you publish papers and you have reviewers, and reviewer 3 is always the worst reviewer. So putting on my reviewer 3 hat and thinking okay, critically here, Stephanie, what could be the worst thing that could happen? Come on. And I think the worst thing would be if you mounted an immune response because the vaccine's gone. So you don't have to worry about that. So now you have memory cells. Now, what happens if those memory cells cross-react with something that we can't foresee, right? Maybe that could be a problem. I mean, that's going to be a problem with any vaccine, but it could be a problem with this one. And so I'd have to go back to the initial development of that RNA and what they chose as the sequences to put into that RNA. And I feel very comfortable that the scientists who developed that would have looked. So we have this database, the NCBI nucleotide database, and it has all of the genomes, publicly available genomes for anything on the planet. So bacteria, plants, animals, archaea, humans, everyone. And they would have what we call blast searched. So look to see whether the sequences they're choosing match anything other than the S protein for coronavirus, for that coronavirus. And they would have chosen sequences that are specific or unique to that virus. So the chances that you're mounting an immune response against something other than SARS-CoV-2 spike protein peptides would be very, very, very low. And so that would, if I'm really being critical about what could possibly go wrong, that would be my thing. I would think that could go wrong. And I think the chance of that is very low based on how it was developed. Yeah. Did that make sense, Jordan? Does that get too technical?
It did, yeah. And that addressed a follow-up to that was specifically with long-term side effects, new technology of mRNA vaccines is different. And the question there is might these new things actually compromise our immunity to new variants of COVID or compromise our body's innate immunity? That was kind of a follow-up question to that sort of
Right. So it's going to okay, so what was the first being worried about? So the innate immune response, but also what was the first one?
Long-term side effects or
Yeah.
compromise immunity to variants or compromise our body's innate immunity. So
right.
you addressed the long-term side effects.
Yeah.
But you were, I thought that was well explained.
Okay, so for variants, this is always a tricky thing with vaccines is developing a vaccine that can not only work for the variant that's around now, but be effective against future variants that you can't even foresee what they're going to be. And you can see with flu vaccines that sometimes we're not that great at predicting that. But with so far, we've been blessed that the vaccine that's been developed does still work with the new variants, even though the variants have mutations in their S proteins. So the mRNA vaccine seems to provide between 80 and 85% efficacy against the Delta variant. Yeah. The trick is, like I mentioned, we've got to stop this virus from replicating before it makes the next variant, because we don't know when we're going to get to the point where our vaccine's not going to be efficacious anymore. Concerns about the vaccine affecting immunity or suppressing or negatively impacting your immune system. The S protein doesn't match anything in your immune system. So the immune system's not going to start targeting itself based on the, mounting memory. And a vaccine itself induces or activates the immune response. So it makes you stronger. Yeah. So I think that concern at this point is unfounded.
Okay. To change directions a teeny bit, pharmaceutical companies seem, apparently in the US primarily, prioritize profit sometimes over the health of their customers. This was what someone had shared with me. And then so they asked, are these pharmaceutical companies like Pfizer and Moderna acting in their own financial interests, or what's going on here? Are they in this to make money, or what's going on?
Well, this is what happens when there's a convergence of business and human health. And this is always a tension. Pharmaceutical companies put a lot of money into development of vaccines, billions and billions of dollars. And of course, they want to recoup those costs and they want to make money. That's what a business is. It is a problem, but I think it's important to know that no pharmaceutical company is going to be able to make a vaccine that's approved by governments, by public health, unless it follows their guidelines and their rules. Yeah. And even in this case, where it did move quickly, they still had to go through rigorous testing. They still had to go through the 3 clinical trials. So the first 2, phase 1 and phase 2, are to measure safety. So phase 1 is a small group of people with dosage and timing. Is it safe? Phase 2 is a bigger group of people. Is it safe? Phase 3 is it effective? And they still had to have very rigorous testing before they were
Yeah.
allowed to go into humans, because nobody wants a vaccine that doesn't work.
Yeah,
Or
it's in no one's interest.
it's in no one's interest. There has been an instance where the US government forced vaccinations of a community, and it ended up that it had negative impacts on that community. No, not negative impacts. It didn't work. And the amount of
What was this
the
for? You said
suing.
forced vaccinations. What was this
Yeah,
for?
I think it was for it was an influenza pandemic,
Okay.
an influenza epidemic.
Yes.
Yeah, in an area in the States in the 70s, I think. I'll have to look up the details, but the amount of money in court proceedings and suing, and
As
after
follow-up
that, it
for
was
that, sure.
just the fallout was horrendous. So nobody wants something like that to happen.
No.
It would be devastating. So, this was done quickly, but it was done carefully. And again, the science behind it was under development for decades.
Yeah. Mhm. Here, another question is related to pregnancy. We have a lot of young families in our church, and and this was about a friend who got their first shot before they were pregnant. Now they're pregnant, but they haven't had their second shot. Is there recommendations? And maybe someone from public health might know better than you, but should they wait until their second trimester, or wait until after the baby is delivered? Is there a recommendation around that?
Yeah, so this is definitely a question for your
Ask your
doctor
doctor.
or your midwife, because there's do you have other health
Pre-existing
conditions?
conditions, yeah.
But on a whole, my understanding is that being pregnant, you're still encouraged to be vaccinated. But yeah, definitely talk to your doctor or midwife about that.
Yeah, I will reply to that person by email and say, please talk to your family doctor, but this is what was said. Okay. I'm gonna go into the conversation here that there are, like I said at the start, a lot of places where people get all their information from, and so one of the concerns is why should we take a vaccine when there is like 99.7% recovery rate and I don't know that number or how true that is or what that means. And is that, is it 0.3% of people that die from the virus, or is it, right, sort of a thing? So when we say recovery rate, I don't even know exactly what that means. So maybe you know better stats on that. But why should we take this if there's such a high recovery rate?
Right. So mortality rate isn't we're not talking about MERS, where the mortality rate's 10% or something like that, or Ebola, where you have an incredibly high mortality rate. I think there's a number of reasons. One of them is one I think I've pretty thoroughly discussed, is the idea of more people being infected means more chances for the virus to mutate. And so if you choose not to get vaccinated and you get infected, you're another person contributing to that chance of creating a gain of function mutation, another variant that could make this worse for everybody. Another reason is because if you're infected, you can transmit it, and you might survive and be okay, but you might transmit it to someone who is not going to be okay. And it's kind of, we know definitely age and some pre-existing health conditions make you more susceptible to serious side effects, but some people get it who are seemingly healthy and die from this virus. So you don't know whether you're going to be that person, or you don't know if you're going to transmit it to someone else, a loved one who is now that person who's going to not do well because you got infected. And a third reason would be because there are a lot of things about this virus we don't know.
Yep.
We don't know about neurological impacts.
That was something that was really scary to me when I first saw some of the news, and it was like people had this brain fog or people had some other neurological things. And I know that's like an infinitesimally small percentage of people who might have that sort of neurological response, but like even in my mind, the potential of like anyone I know, having this and just neurologically be affected for the rest of their life is a pretty terrifying prospect.
It is. There's links to depression and anxiety and um, uh, and then there's the long haulers. So people who just seem to not be able to shake
Yeah.
this feeling of, achiness and lethargy and brain fog. And there's a whole group of individuals who have that as well. And so you could be one of the people who get infected and clear it and are A-okay, or you could not. And there's really not a whole lot of predictors about how you'd fall on that line. So I think an important thing to think about whenever you're thinking about a vaccine is evaluating for yourself the risk of the vaccine versus the risk of the disease.
Hmm.
And do you feel the risk of the vaccine is greater than the risk for the disease? Then don't
Hmm.
get the vaccine. If you think that the disease is of higher risk than the vaccine, then it's important to get the vaccine.
Yeah. No, that's really helpful. Question, you did talk about like antiviral drugs, and hydroxychloroquine was one of these ones that the former president apparently was touting for some time, and there's another one, Ivermectin, mentioned in a question. Apparently, someone said to me that they've proven successful in recovering most patients. Why was this not used as a medication during COVID? You already said earlier that antiviral things weren't effective. Do you want to maybe just expand a little bit on that?
Yeah, so antiviral drugs, those two in particular have been tested in large randomized trials, clinical trials, and neither have been proven effective in randomized clinical trials. So neither have been adopted by the FDA. There's definitely what we call N of one medicine. So one-off patients or groups of patients that have been reported to have positive responses to those drugs. However, when you bring it to a larger group of people in a randomized trial with a placebo group, and it doesn't pan out. And viruses, I tell my virology students, viruses are slippery little pathogens. Like they are really difficult. They mutate. They're hard to target. And one of the reasons why is because when the virus gets into the cell, it starts using the cell's machinery. And so how do you stop the virus without killing the cell? Because the virus, it's almost like it puts on the cell suit and it uses everything in the cell. So it's very difficult to develop a drug that hits the virus and doesn't hit the cell. And then to develop a drug that then after that will stop the virus before the virus mutates around it. And this is a reason why for HIV infections, you need to take a cocktail of drugs because one drug is not going to work. And why for influenza, Tamiflu just reduces infection or reduces symptoms by a day or two, and it actually doesn't stop the virus because they're really hard to make. And it's another reason why don't rely on antiviral drugs instead of a vaccine to protect you from this virus because they're just not up to snuff.
Yeah. Masks became something that was politicized, and there were no more masks, or and we say anti-mask or protests and these sorts of things. So someone emailed in and asked, why should you wear a mask if breathing carbon dioxide is detrimental to your gums and teeth, apparently your overall health? And then masks, this person stated, was that are not proven to be effective for COVID, where you said you were with your science hat on initially, said that masks, cloth masks, what difference does that make? And then you were actually surprised. So maybe share a little bit about your journey with cloth masks, but then also just speaking to our health with carbon dioxide and masks and this sort of a thing.
Yeah, so I think I can address the carbon dioxide pretty quickly. Carbon dioxide is much smaller than a virus and can diffuse through fabric, through an N95. You will not accumulate toxic levels of CO2 when you breathe in a mask. So you don't have to worry about CO2 in a mask. It's going to diffuse out of the mask. So
I
that's
do woodworking sometimes, and I wear an N95 when I'm either doing some really fine sanding, and
Mhm.
I don't like that's a normal thing. I'll wear it for hours, an N95, and I'm sure many people in their jobs do that too. So
Well, if you think in healthcare professionals, they're going to need N95s. When we work in the lab, under some instances, we need N95s. And so they wouldn't be developed if you had to worry about carbon dioxide
okay.
toxicity. With fabric masks, yeah, I mean, as somebody who works with N95s and works with viruses, I'm like, what are they talking about? Cloth mask on your face, sew your own masks. I'm like, oh my gosh, yeah. And then and of course, but then N95s weren't available, so they had to all go to medical professionals. So then what can we do to protect ourselves? Well, I'm sure fabric's better than nothing, and then it turns out fabric is better than nothing. This study that came out looking at states that reopened in the United States. So they went into lockdown and then they reopened. And they looked at states that were that opened but required masks, and those that opened but didn't require masks. And in the number of cases per 100,000 residents, the states that were reopening without masks had 10 times more infections than states that required masks. So they were incredibly effective at limiting virus transmission. And also death rates were reduced by 80% in states that required masks upon reopening.
Wow.
So, part of it, I think, is, yes, it does block the, aerosolized particles from, so when you sneeze, it's this rapid fire of
I've seen those
mucus and
disgusting
snot
images
and
when someone
yeah.
sneezes and you see the freeze frame of the particle. It's
Yeah,
like,
yeah, yeah,
oh,
yeah. So with the cloth, it slows that down, right? So you don't get that effective dispersal. So they think that's the most effective reason, like that's the reason why the mask is effective. But I think also when you're wearing a mask, you're just more aware. You have something on your face, you physically remember you're supposed to stay away from people. And I think that's also something too that's contributing to this effectiveness of masks. Is like, have a mask on. Oh yeah, I can't give you a hug right now, or I gotta stay 2 meters back.
Sure.
So but yeah, there's definite evidence that even cloth masks work.
Very cool. We're past 9 o'clock. Initially, I said, yeah, we'll go to 9, but I felt like Stephanie's presentation was great, and I think it was a good length. It wasn't too long. Don't worry. I thought it was excellent. There was, I think, 1 or 2 more questions in the chat, but I do want to, if you're cool to stick till maybe 9:15, or we'll see if there, I don't imagine loads of people wanting to stay on this Zoom call. We've been on enough Zoom calls in this pandemic. Beth asked, how long would it take for side effects to show up? Could something show up, say, 5 or 10 years later if you're, after taking a vaccine? How does that work?
Right. So what are the side effects against? I guess what's triggering the side effect? The vaccine itself is gone. So we already talked, the protein is degraded, the RNA is gone. So the only thing that's left is the memory, those cells that have the matching receptor to the S protein. So that's the only thing you'd have to be worried about at that point, right? Everything else is gone. It's degraded. It's not there anymore. Now, one thing could be, does that receptor bind to something else and activate your immune system to something wrong? Now, if it's part of your body that, let's say we made a mistake and we developed this vaccine against something that matches, or that receptor would be similar to something in your body, it would happen instantaneously. You would have an immune response. If the vaccine caused an autoimmune response, it would happen right away. So we're not seeing that. Millions and millions of people are getting vaccinated, and we're not seeing autoimmune responses. So when they developed that first, which sequences do we put into the vaccine, and they screened everything and they looked for unique sequences, they did a good job. they're not seeing inappropriate immune responses to things in your body. I guess there's a small chance that maybe something down the road could match that receptor and cause an immune response, but we'd likely see it. We'd be seeing evidence of that when you've got a global scale vaccine strategy. You'd likely see that soon. It wouldn't be something that would take years down the road to pop up. I'm trying to put on my reviewer 3 hat
You're
and think
reviewer
of like
number
critical.
3, the most critical.
Yeah, the worst one. And I genuinely, like, if it was a more complex vaccine, if it was something that left something in your body, maybe, or if it had, but this is such a simple, this RNA vaccine is such a simple vaccine. I can't imagine what it would be.
Your thoughts on mixing vaccines? Nothing most people can do about it now. Someone shared, Kim shared that she had AstraZeneca first time around and had Pfizer the second time. I already shared I had Pfizer the first time, I had Moderna the second time. I heard the comparison as, and this is a genuine question of mine too. It's like, oh, it's both like, it's like a Coke or a cola product. One's Pepsi, one's Coca-Cola. But I saw the CDC said, if you got Pfizer, you stay with Pfizer. If you got Moderna, you got Moderna. Another virologist I'm familiar with at U of T said, no, like it's all good. They're like, but you already shared that AstraZeneca is different than a different type of, vaccine than Pfizer. So what are your thoughts on mixing?
So the reason why our Health Canada is saying if you've had Pfizer, stick with Pfizer is because that's how the clinical trials ran.
Yeah.
So, all of that stringent testing and approvals was with that strategy.
Yeah.
However, there is HIV. For years and years, scientists have been trying to make an effective HIV vaccine, and it is one slippery virus. It's very tricky. But the best strategies so far have been mixing vaccine platforms. So doing a prime with one platform and doing a boost or subsequent boosts with different platforms to mix up the immune response, get some different things stimulated. So yes, it's probably safest to stick with the same platform because
it's been tested and it's been through trials.
But you actually might get a better immune response if you had AstraZeneca the first time and RNA the second time. We don't know. I would say, what are it could be either you could get a worse response, the same, or better. And I think it's very unlikely you're going to get a worse response with a mixed platform. So you're either going to get the same or better. But again, we're doing, I was talking to my doctor who said it's like building a plane while you're flying the plane is how public health is running right now, trying to figure out how this works. So
Kim is happy to hear of what you've shared. Just so
okay.
You know. There's a few and smiley face. She's very happy to hear this.
Yeah.
No, that's
okay.
good. Something again, like I don't think too much of our conversation has been too tense. Sarah asked a question about a colleague in your same profession that has differing views. The name here I'm not familiar with is Brian Brittle. I don't know who that is.
Byron Bridle, yeah.
Brian Bridle. And how do we as lay people, filter through different types of professionals saying different things? So maybe just say a teeny bit about, because I don't know the context, and then just share what you think is appropriate for us to understand.
And I think that's a really legitimate question because you're getting inundated with information from trained professionals, and when they conflict, well, what are you supposed to do? And I try to think about this after Dr. Bridle. So Byram and I were postdocs in the same institution. We actually were in labs beside each other, so I do know him. He trained me how to isolate monocytes from a spleen. Anyways, he
Not something friends normally do with one another, but you know, when you're doing
No?
postdoctoral work together, what's a something with a spleen? Okay,
monocytes from a spleen. Let me
Very
tell
good.
you, it was very satisfying. So anyways, Dr. Bridle has concerns about the S protein
Okay.
and about it possibly being toxic. And I think what you need to know then as a layperson who is hearing all this information is, okay, what do other people say? You know, evaluate that information and say, is that true? Let me look at some other professionals. Do they agree with that or not? And in this case, I think the majority of scientists would not agree with Dr. Bridle's opinions. And I could talk about some of the. We talked about how that S protein, the coding in the RNA vaccine doesn't code for the whole S protein. It just
I thought that
codes.
was fascinating. You said it just codes for parts of the spike protein, which is something I didn't
Mhm.
know before tonight, and that I think that's very cool.
Yeah, and I think some of Dr. Bridle's concerns are concerns about the S protein as a whole, but that's actually not what's coded in the vaccine. And then some of his concerns are with it circulating and getting into your your circulatory system, so in your blood vessels. But again, we're not talking about the whole protein. We're only talking about pieces, and we're only talking about a protein that's going to last in your body for maybe 2 weeks. So long-term effects, like what Dr. Bridle was explaining, I have a hard time envisioning, because S protein's just not going to be around. Those fragments aren't going to be around for that long. Um, and everybody has the right, even scientists do have the right to freedom of speech, you know.
Yeah.
But as people who maybe don't study that, you need to then assess that in the context of other scientists and say, does it match what other scientists are saying or not? And if, you know, if 10 scientists say no and one says yes, there's always going to be someone who's going to say something different. But you know, that might be one way of evaluating um claims or
Play the field.
what yeah.
See what else is out there. Those are all questions that I've seen in the chat and that I've reviewed from emails coming in. It's quarter after, so if anyone is like has a burning question, either throw it in the chat or unmute yourself and say, hey, I'd like to ask a question. But I'll give like a minute for that to happen. But otherwise, I'll say thanks and wrap up in prayer again too. So I'm waiting for the chat, waiting for an unmute.
Well, thanks, Jordan. Thanks for while we're waiting, thanks for letting me have this opportunity to speak to people at the meeting house about this, because there is a lot of information out there, and it's hard to sift through it. I'm happy to help. I also, like, science is changing all the time. Like, I was updating the variants and I had to keep updating, and then I updated it and then I heard about lambda. So it, you know, science is happening at such a fast rate. It is difficult to keep up with it, even as a scientist in the field.
Yeah, no, I mean, kudos to you. I mean, you got to update these slides every time you share a little something with someone else. Thanks for coming in the chat as well too. And someone asked as well about if this will be available afterwards, and I said yes. This was recorded. I'm not sure precisely where I'll post it to. I mean, I'll probably post it to the meeting house, like Waterloo's like Facebook page, but there's also like a YouTube link that might be easier for people who aren't on Facebook. I'll make that available, because there were multiple people who said, I can't make it, but I'd love to hear what's shared in the questions. And so I think this will be a good resource for those who couldn't make it. So yes, huge thanks to you, Stephanie. I'm super grateful for your wisdom and knowledge and experience, and just, openness to just be like, yeah, I'd love to do this. I'd love to share. I'd love to help that means a lot. I think it's you using your gifts to for everyone, for the world, building up the church, but also just extending them out from here. And Andrew, who's been our tech guy, he's been behind the scenes. Thanks, Andrew, for making everything work. I appreciate that a lot. Appreciate your presence for being here. And then I'll just pray. Say, Jesus, thank you for tonight. Thank you for your church, for your body, and all of its parts. Some of us become scientists and love to study the body and love to study teeny tiny parts of the body that are so much smaller even than a human hair. And you are the creator. You've created all things. You sustain all things, and we are so grateful to you for life and everything that it is. And in this time, a time of confusion, a time of stress, often a time of loneliness and depression, Jesus, we're thankful for your body, for your church, and for friends like Stephanie who can share their gifts with the body, and that we can say, hey, we need help from one another. And so even as we said, hey, we need help from you, Stephanie, that we as a church would be saying, hey, we need help from one another, acknowledging our own needs, and so that we can better be a community, relying on one another's gifts and relying on one another's strengths. So thank you, Jesus, for this evening. Yeah, for everyone who's joined us and for everyone who will check this out later. Amen.
Thank you. It was awesome.
Thanks for coming, Beth.
We'll end the recording, and then if people want to hang out, they can too.